I am Dr. Sampath Kumar from the Meenakshi Mission Hospital, Madurai. At the outset, I would like to thank the Kidney Warriors Foundation for giving me this opportunity to share my thoughts on what can better be done for our patients with kidney disease. The topic that I would like to discuss today is uppermost in my mind. Let us listen to the patients. Over the 30 years that I have been a nephrologist, I have seen the winds of change in dialysis practice in India. Dialysis in the past had a very low pickup rate of renal failure patients due to the lack of awareness and also due to the lower incidence of chronic kidney disease. And the dialysis units were monitored by nephrologists alone. Patients' loads were low and there were low number of long-term survivors. But when you zoom into 2020, there has been a paradigm shift in the way that dialysis procedure and dialysis facilities are offered to the patients. There has been a tremendous increase in the awareness about the role and the importance of kidneys in normal health, and consequently the pickup rates of renal diseases have increased. The awareness and pickup rates have gone hand in hand. And now we have come to the other end of the spectrum where almost 70% of the dialysis units in India are monitored by nurses and technicians. The patient load is rather high, and what is good is that we have good amount of people who are surviving for long term. But the question remains whether it has translated into better dialysis care. In other words, has it improved the patient's quality of life? You can debate about it for hours to days, but there are two ways of looking at it. The proponents will say that dialysis has become more affordable and more people are on AV fistula rather than catheters, which makes it much easier, and more number of patients are on medications like erythropoietin, which really does have a say in improving the quality of life. The opponents would like to say that dialysis, the quality of life has not improved. There is more science has gone into it, but there is less personal touch in modern medicine and nephrology. And the patients would like to tell us that they are not given a patient hearing by the nephrologist. The doctors, technicians, and nurses are more concerned about what is flashed on the screen of the dialysis machine, the pump flow, dialysate flow, sodium, potassium, etc. And they don't tend to give that much importance to the poor patient who is hooked onto the machine. There is an adage in the English that don't put the cart before the horse. But in dialysis, you have to put the man before the horse. If you don't do that, then you are in for the patients are in for trouble. It is because it is more important to know what sort of patient is having the disease than to know what sort of disease the patient is suffering from. Most often, we nephrologists are intrigued by the diseases and we are challenged by the intricacies of the diseases. But we often forget the type of patient that is sitting in front of us. So on this score, I would like people to look to the east rather than to the west. We always have a tendency to think that whatever comes from the west is the best in the world. But as far as the dialysis practices are concerned, the, the nephrologists of Japan have lots to teach to us. This is the editorial written by one of the pioneers in dialysis in United States, Christopher Blagg. He says that Japanese patients survive better on dialysis than United States patients, though they do not have cadaveric renal transplants. And they do so because dialysis is done with less pump speed. See, what we think is that the speedier the pump speed is, then better the dialysis care. But the slower forms of dialysis does have a role to play in improving the quality of life. More prolonged dialysis is the way to go. And Japanese doctors spend more time with hemodialysis patients listening to them. So this is again a very important part and parcel of our life. So science versus symptomatology. What is science tells us? Weekly 3 times dialysis is an inviolable rule. You have to put the patients for 3 times a week. KT over V, a form of measurement of dialysis quality, has to be done regularly. High blood flow in the fistula, which shorten the dialysis times, is the way to go in the Western countries. American model, unfortunately, has many critics, and so we have to follow the Japanese model. And there is a gap between what the patients want us to listen to and what we think is important to the patients. There is a gap in the symptomatology perception. For example, if a study was done which showed that close to 70% of the patients have said that they were feeling down and out and feeling tired, but only 45% of the doctors said, yes, we know about it. And 25% of the doctors said, we don't know that whether this patient is feeling tired or not. In the same way, dry skin, dry mouth, itching, trouble staying asleep, trouble falling asleep, all these are felt by the patients. But see, very low percentage of doctors knew about it because they never listened to the patients. So how prevalent? So I will take up only 2 major issues which really haunt the patients, which reduce the quality of life for the patients. One is itching. The other is pain. So how prevalent is pruritus or itching? The prevalence of moderate or extreme itching is close to 1/4 of the dialysis population suffer from itching, and it is more likely in elderly and in females and patients who have diabetes. So very important, and patients who are depressed. So this produces really reduction in the quality of life, how you perceive that you are satisfied with life. And the mental component is also coming down, and the depression symptoms are going up when somebody has to scratch all the time, and this also interferes with their sleeping. So there is a very high prevalence of itching in non-dialysis kidney disease, and also in dialysis patients. It is associated with reduced quality of life. So, and you can see another issue, that once somebody, when the doctor tells the patient that you require dialysis, then you see how low he goes in the psychological sphere. There is depression, there is adjustment disorder. So all this happens when he is diagnosed with a condition where lifelong dialysis is required. So you require a psychological counseling. And what bothers the patients are pain, lack of energy, sleeplessness, itching, and lack of appetite. All these have to be addressed. As far as the pain is concerned, it is most of us doctors, we just prescribe a pain relief tablet and then move to the next patient. But we have to do much more. See, the physical pain is associated with general fatigue, itchy skin, shortness of breath. You need to look at the psychological aspects of pain, because sleep disorder, anxiety of the complications, denial of dialysis. Even a patient who has been on dialysis for many months yearns for a period where he will be not depending on dialysis for his life. So he always yearns for a period where he can be taken off dialysis. The social pain also cannot be forgotten. The time constraints, labeled, there is a social stigma. The patient is a person with a disability, and barriers and discord within the family. I have seen families disintegrating in patients who have requirement for long-term dialysis. Your own kith and kin may no longer be very close to you, and you have the drug therapy, which is psychotropic drugs, which are traditional psychotherapy. All these are very important. The supportive psychotherapy is also very important. You need to address the fear of death, decision of dialysis, discontinuation, isolation, loneliness, life that depends on dialysis. All these have to be looked into before you provide a wholesome treatment for pain. So one of the, again, a very important pain promoter is recurrent needle pricks, is one under-recognized factor for anxiety and depression in hemodialysis. So you need to do an alphabetical approach. So P, Q, R, S, T. P, what provokes the pain? What relieves it? And what is the type of pain that the patients have? And what is the region where the pain is coming from? What is the severity of pain? And when did it start, and what are the pain-free periods? So these patients can be given two groups of drugs. One is opioid groups. Opioid groups have slightly higher chances of addiction. The problem with the other group, the so-called NSAIDs, where it is freely available over the counter, is that these patients can have issues like gastric ulcers, etc. So what alternatives can be proposed for patients with pain in dialysis patients? You need to provide them with some form of aerobic exercises. They can walk about, and this again reduces the chances of pain. They can do stretching exercises, mild stretching exercises, massages, acupressure, acupuncture. All these can be tried in patients with pain. And the NSAIDs have problems of gastrointestinal bleed, so you have to be careful. Only these drugs have to be taken with a prescription of the nephrologist. Codeine and tramadol, all these drugs are available, but you have to approach the nephrologist for pain relief. So how do you do it? You start with the tablets, slowly hike up the dose of the tablets and give them regular tablets so that they can have these tablets on a regular basis. So trial each step for 1 to 4 weeks before progressing, and depending on the pain severity, you can provide good pain relief. So the other issue is the itching and dialysis. So 40% of the hemodialysis patients were at least moderately bothered by itchy skin, and 70% of the nephrologists underestimated the prevalence of itch among their patients. So you can use moisturizers. These are available. So you can give moisturizers. See to it that the skin is always moist, and that really reduces the chance of itching. And you have drugs like Montelukast, gabapentin. These are available. You can discuss with your nephrologist and have these prescriptions so that you can get relieved to a great extent from itchy skin. And you can see that a variety of patient reported outcomes are there: vomiting, diarrhea, nausea, constipation, poor appetite, uh, uh, feeling anxious, worried, drowsiness, difficulty in sleeping, poor mobility. All these have to be discussed with your care provider like nephrologist. And you can also carry a chart which are available in the internet. Have a self you can do this charting with the help of these Likert scale, and then see how good you're progressing on dialysis during the past 4 weeks, what extent you are bothered by all these. So you can have these charts which are freely available, downloadable, and then you yourself can uh, gauge whether you are getting better or worse, and then take it to the care provider like a nephrologist and tell them, sir, I was like this, now I am not doing well, so provide me with better medications. And family and friend interactions are also very important. So all these have to be put into your daily care when you are talking to the nephrologist. So friends, I have just highlighted on loud thinking as to what can be done better with the interactions of the nephrologists and care providers with the patients. And so as care providers and nephrologists, we would always like to have the smiles and the rainbows back to our patients' lives. And any endeavor which goes a long way in providing these will be good. And I'm sure a talk like this also goes a long way in touching all the lives of patients on dialysis and patients with chronic kidney disease, and to tell them that we as nephrologists are duty bound to listen to you and see to it that you lead a better life than what you're leading now. Thank you.